Thank the organizing committee for inviting me here today. It's my great pleasure to be here to present this subject of optimizing the administration of analgesic agents using ANI. It's called the next step towards personalized anesthesia. We've seen cortical phenomena, and now we are going to the subcortical area. So these are my declaration of interest, and one of them is with M. Dolores Medical System, which is the manufacturer of the ANI monitor. So this is the monitor. I've seen that there is one in the exposition area, so you can see it further. So the basics of ANI calculation is based on heart rate variability. And heart rate variability is based on respiratory sinusal arrhythmia, which means that at each inspiration there is a small increase in the heart rate, so a decrease in the RR series, and at each expiration there is a slight slowing of heart rate, and then the RR intervals are wider. So this is the representation of the RR series, and during the normal state, when there is prominent parasympathetic tone, like during analgesia or like now, for example, there is variability, heart rate variability, which is linked to the influence of respiration. So this is what you can see here. But in case of activation of the sympathetic system, such like during nociception, for example, you can see here on this curve that the heart rate variability is suppressed. So to be really, this is important for further. So to be really, this is really important to understand that during sympathetic activity you have great variability, and during parasympathetic activity you have variability, and sympathetic activity like nociception you don't have variability. And this is the principles of ANI calculation, because you have here, it gives the EKG signal, and it calculates here the RR variations. So this is heart rate variability. And this is during 1 minute. And this is the window is divided in 4 sub-windows here. And the ratio to the smallest surface here to the total surface here is indexed to 100, and so it's not really important to understand the calculation, but just to understand the concept. This is a ratio to the small surface to the big surface, and indexed to 100, and it gives you a number varying from 0 to 100. 100 is maximal parasympathetic activity, and 0 is no parasympathetic activity. And meanwhile, when you have 100 parasympathetic activity, you have 0 sympathetic activity. So it's like sort of yin-yang system, 100, 0, 0, 100. Analgesia is 100, and nociception is 0. So you can have this on the monitor. So now let's turn to the different clinical studies that have been performed with this monitor. The first one was here during labor analgesia. So pregnant women without epidural analgesia were studied, and they had this ANI monitor. And the VAS pain scores were compared. In white here, it's without uterine contraction, so during analgesia. And in gray here, it's during contraction, during pain. And you see that the VAS pain score, the pain scores were higher during contraction, but at the same time, the ANI values were lower here during contraction than without contractions. This is the representation here of ANI values and pain scores, and there is a negative linear relationship between the values, but as you can see, with much variability, with a R index of O, well, quite slow. So there is a linear relationship, but much variability. We then published this study to assess the postoperative pain in PACU. So after surgery, so we included 200 ASA 1 to 2 patients undergoing general anesthesia, combining halogenated or propofol hypnotics with remifentanil during ear, nose, throat, or plastic surgery or ENT endoscopy. This is what we are doing in my unit, so that's why we choose these patients. And the ANI and the pain score, numerical rating scale 0-10 pain score, were measured at arrival and in the end of PACU. And what we observed was, once again, this linear negative relationship between ANI values and pain scores. The higher the pain scores are, the lower the ANI values are, with variability again, but there are two here, coefficient of determination of 0.41. And more interestingly, this is on this diagram, you have here the ANI values at arrival in PACU and in the end of PACU. The blue one here are people who arrived in, patients who arrived in PACU without pain. You see NRS pain score less than 3, and their ANI values were high, more than 70, 75. But patients arriving in PACU with pain, NRS pain scores more than 3, had low ANI values. And in the end of PACU, after providing adequate analgesia to the patient with initial pain, then you can see that all the ANI values, were higher and approximately 70, 75 in the end of PACU. So after analgesia, the people having low ANI values initially had higher ANI values in the end of PACU. And so we could determine the performance of ANI to detect patients with NRS pain scores more than 3, and the threshold was 57. If the ANI values were below 57 or below 60, then you had this performance sheet: 78% sensitivity, 80% specificity. To detect NRS pain score more than 3. And more interestingly, the negative predictive value was of 88%, which was the higher score here, which means that with high ANI values, you are pretty sure that your patient don't suffer from pain. With low ANI values, they may suffer from pain, but for other causes of activation of the sympathetic system, so for example, anxiety, emotion. But with high ANI values, people are adequately have adequate analgesia. So after having published this study, my question was, maybe it's okay to have a monitor to detect pain, but maybe it's easier just to ask the patient, do you suffer from pain? If he can communicate, it's easier. But one question was, maybe was it possible to predict immediate postoperative pain with the ANI monitor? So we performed the same study, but the ANI was used immediately during general anesthesia, immediately before extubation of the patient. So we had 200 patients, ASA 1, 2, 3, undergoing inner throat surgery and orthopedic lower limb surgery, painful surgery, regarded as painful surgery. And we wanted to control for the anesthetic agent that they received, because on the previous slide, I won't be long on this, but on the previous slide we showed difference between desflurane, propofol. So to really have a homogeneous group of patients, we wanted to have only desflurane and remifentanil patients, and plus or minus cisatracurium if needed. And the ANI was measured, recorded immediately before extubation. So the remifentanil and desflurane were stopped. The patient began to arouse from general anesthesia, and the ANI was recorded immediately before extubation, because extubation in itself might be a nociceptive noxious stimulus. So immediately before extubation. And we recorded the pain scores, NRS pain scores, a few minutes later at arrival in PACU. And what we observed again was this negative linear relationship of ANI before extubation and NRS pain scores at arrival in PACU, with R2 of 0.33, variability again, but a relationship. and quite a good performance for ANI to predict immediate postoperative pain with an array under the ROC curve here, which corresponds to the PK probability of 0.89, which is good. And with an ANI less than 50 immediately before extubation, you can predict with good performance, 86% sensitivity and specificity, the occurrence of pain scores more than 3 at arrival in PACU. The ANIs were also studied, the variations of ANI were studied during abdominal laparoscopic surgery in adult patients undergoing appendectomy or cholecystectomy with using a total intravenous anesthesia, combining propofol with a BIS target 40 to 60, remifentanil, and cis-atracurium. I'm sorry, you can see the names of the reference, but... And this is really interesting because these are the results. This is hemodynamic parameters. So in black here, this is heart rate during surgery, different times of surgery, no stimulation, during insufflation of pneumoperitoneum, at incision, etc. So during the different times of surgery, heart rate was around 60, quite controlled, and there was an increase here in systolic blood pressure, here in white. And interestingly, patients were monitored using BIS and using ANI. And you can see that the behavior of the two monitors were totally different. With BIS values here in blue, you can see that the range 40 to 60 was maintained during surgery, during general anesthesia, whereas ANI values were initially high. You see here, this is 100 to 80 to 100. And during the different stimuli, the ANI values were down, 60, 40, less than 40. And then in the end of surgery, ANI values were high again. So it's really important to understand that anesthesia is just, you can't monitor anesthesia with just only one parameter. There is conscious, there is pain or nociception, and this is an interaction between, but you can't resume anesthesia monitoring to only one parameter. It's just like wanting to resume hemodynamics to one parameter, whereas you have heart rate, you have blood pressure, and it's the combination, the variation of both that is important. So ANI is a monitor for nociception, and BIS is a monitor for hypnosis or narcosis sedation, but not a monitor for nociception. This monitor was also studied in children, and 12 children undergoing middle ear surgery using desflurane with remifentanil at varying doses, and the children had tetanic ulnar stimulation during anesthesia. And these are the results. Here you have decreasing concentration of remifentanil going from 0.2 nanogram per milliliter to 0.04. And in gray here it's before tetanic stimulation, and in black here it's after tetanic stimulation. And you can see that after stimulation there is, after stimulation there is a decrease here and here and here and here. There is a decrease in ANI values, but this decrease is more pronounced here with low remifentanil concentration, whereas here there is a decrease, but a smaller decrease here with high remifentanil concentration. So it's really important to understand that there is a balance between nociception, anti-nociception, and if you have, because for the same stimulus, the same noxious stimulus, you have different responses to the stimulus depending on the concentration of remifentanil. And the influence of nociceptive stimulation was also studied during total intravenous anesthesia for adult patients undergoing surgery, and the the time of recording was the laryngeal mass insertion, and the patient received propofol with a BIS target to 30 to 60, and again remifentanil at varying doses with this tetanic ulnar stimulation, so somewhat the same design as the one presented for pediatric patients. And we had similar results here. It's just the other way around because this is increasing remifentanil concentration. So this was LMA insertion, and then these were the time of noxious stimuli with tetanic ulnar stimulation. So R is 0 remifentanil, 2 nanogram per ml of remifentanil, and 4. And you can see here again that there are variation drop in ANI values after stimulation in comparison to before stimulation, but the decrease in ANI values is much pronounced when there is no remifentanil, when there is no analgesia for the same stimuli, whereas here you have the same stimuli but a low ANI drop with a high remifentanil concentration. Then also a balance between nociception and anti-nociception, and a higher response when there is inadequate or low analgesia. We also published this study to assess the prediction of hemodynamic reactivity during ENT endoscopy. So 50 patients undergoing suspension laryngoscopy with total intravenous anesthesia combining propofol and remifentanil, and different time were measured before procedure T0, 1 minute after the beginning of the procedure, during the procedure, and in the end of procedure. And hemodynamic reactivity was defined by a rise by more than 20% of heart rate or systolic blood pressure within the following 5 minutes. Because the important thing was to assess this variations of ANI values in spontaneously breathing patients, although they were under general anesthesia, because during ANT endoscopy in our unit, we don't intubate the patient unless there is apnea. But we have to maintain 5 minutes. Oh, I need to be really quick. Okay, so we had really good performance of ANI to predict variations of ANI heart rate. Hemodynamic reactivity 0.9, so it was useful in this context too. And then what was this one? We did the same study during ENT or orthopedic lower limb surgery with desflurane, remifentanil, and cisatracurium, and the ANI values were measured, but the variation of ANI in 1 minute was studied this time. And this is our results. This is just for, when you look at ANI values, then the performance is 0.75. But if you look at the variation in 1 minute of ANI, the performance is much better to predict hemodynamic reactivity. And the variation of minus 19% of ANI in 1 minute can predict the occurrence of hemodynamic reactivity with very good performance, 0.9 here, during general anesthesia. Okay, so I'm in my 5 minutes. So this is the next step, and it's experimental for the moment, but the laboratory in Lille, who is working on ANI, is currently working on a closed-loop system to administer remifentanil according to the ANI values. So this is just one publication. It's experimental. It's not released yet, but this is the future, perhaps, of remifentanil administration, like the automatic pilot. So to conclude, in anesthetized patients, you can observe decreased ANI values during nociception in both adults and children before hemodynamic reactivity, and ANI values, ANI monitoring allows for the prediction of intraoperative hemodynamic reactivity and immediate postoperative pain. Just a few, perhaps I have one or 2 minutes. Oops, no, it's almost over, so it's okay. It's okay. I'm on time. Yeah, that's it. So in conclusion, ANI allows for a continuous measurement of nociception, anti-nociception balance, and may allow for tailored personalized analgesia, in particular when using remifentanil. I didn't show the results using other opioids like morphine or fentanyl, which are the PK, the pharmacokinetics are maybe too slow to be monitored with ANI, but with remifentanil it's really interesting. And an ANI, maintaining ANI values above 55, 60 it may be useful to optimize intraoperative analgesia and post-operative pain management. I thank you for your attention.